So I have no disclosures. I do have a few questions. We can deal with this in the end. Sorry. So this is the outline of the talk today. We're going to talk a little bit about selecting the frontline tyrosine kinase inhibitor in CML patients, and then monitoring their response on therapy. Also talk a little bit about resistance, different kinase domain mutations, and also selecting a salvage TKI. And the other exciting part of CML is able to stop tyrosine kinase inhibitor in a select group of patients. Most people ask what's new in CML, so that's probably the most exciting part of CML is treatment-free remission. So most oncologists are really comfortable in managing CML patients, but one thing that I would like to highlight is a diagnostic bone marrow is important to document any additional cytogenetic aberrations in addition to the Philadelphia chromosome. It doesn't happen all the time because of the availability of BCABL testing in the peripheral blood, but I would encourage everybody to do a bone marrow evaluation at diagnosis. And then you also come across rare situations where karyotype testing comes back negative for Philadelphia chromosome. That's because of some unusual and variant translocations that are reported in a small percentage of patients. In those situations, BCABL FISH would be useful, so I would definitely recommend considering a BCABL FISH in the bone marrow aspirate in addition to the conventional karyotype. So the reason it's important to document the additional cytogenetic abnormalities, see, this is a study that was published a long time ago, that patients who have additional cytogenetic abnormalities in the bottom curve, the green one, have worse outcomes. And the type of, based on the type of abnormalities, they were reported as a major route or minor route. Minor route abnormalities don't really impact the outcome, but the major route abnormalities are presence of an additional Philadelphia chromosome or trisomy 8 or trisomy 19 or isochromosome 17. These patients have worse prognosis when treated with Imatinib alone. So you should definitely consider evaluating for a transplant while you start them on TKI. So the first study that showed the benefit of TKIs is the IRIS study. This was randomized CML chronic phase patients to Imatinib 400 milligrams once daily versus interferon on cytarabine, which was considered to be a standard of care then. And these are long-term published data. You don't see the difference between the two curves because almost within 6 months, everybody on the cytarabine interferon arm were crossed over to Imatinib. But what is important to notice here is that at 10 years, the overall survival was about 83%. So people treated with Imatinib do really, really well. And the most important part of this publication is that there were no serious long-term toxicities emerged even after 10 years of treatment with Imatinib. So Imatinib is an excellent choice in majority of the patient. But the other thing that I would like to highlight in here is that the responses were not as good in high so-called risk patients. Here, the survival in low-risk patients is about 89% at 10 years compared to only about 68% in high so-called risk patients. So it's so patients with high so-called risk should probably consider a second-generation inhibitor. So this is a real-life kind of study on how patients with Imatinib, first-line treated Imatinib patients do. This was done in Liverpool in UK. And in the bottom, what you see is at 2 years, out of, I think, over 70 patients, less than half of the patients, that only about 28 were able to continue Imatinib in a good response. So what we're seeing in the clinical trials is probably not the same in real-life practice due to various issues, maybe compliance, lack of stringent monitoring, and identifying issues with adherence or resistance. So in terms of the using second-generation tyrosine kinase inhibitors up front, there were two major phase 3 randomized studies. The first one is ENESTnd. It's a multi-center study, 217 centers total, 35 countries. At the time, the optimal dose of Nilotinib was unknown, so patients were randomized in 1-to-1 in fashion to either Nilotinib 400 twice a day or Nilotinib 300 twice a day, or versus Imatinib 400 once daily. And the primary endpoint was rates of major molecular response at 12 months, because major molecular response is considered to be an excellent surrogate for long-term outcomes in patients with CML. And it's difficult to show overall survival benefit when your patients do so well for many years. So this was the 5-year update. Sorry, the pointer doesn't work. The patient dispersion at 5 years, about 60% of the patients in Nilotinib arms were still on the drug at the end of 5 years, whereas about a lesser number of patients, about 50%, were on Imatinib. And the reason for discontinuation was kind of highlighted in the bottom part of the table, either due to adverse events or treatment failure. So the cumulative incidence of MMR is significantly higher in patients treated with Nilotinib. At 1 year, there was almost 25 to 30% difference in comparison to Imatinib, and this was maintained up to 6 years, where you can see that almost 80% of the patients treated with Nilotinib had a MMR, as opposed to about 60%. And this is MR 4.5, which is basically considered as a deeper molecular response. The relevance of MR 4.5 comes in mostly in the setting of treatment-free remission. That means able to discontinue TKIs. So the rates of MR 4.5 also much higher in patients treated with both arms of Nilotinib as opposed to Imatinib. And in terms of progression, encore treatment is basically include only events that happen while they're on the assigned TKI, as opposed to on study, patients who were switched to a different TKI were also followed. And on study, you can see that there were more progressions in the Imatinib arm. About 7.4% progressed to accelerated phase of Blaschkreis at 5 years, compared to 2.1%, or I think it's 3.9 in the Nilotinib arms. So there's some benefit in terms of progression, reducing the probability of progression to accelerated phase or Blasch phase. In terms of overall survival, there was no significant benefit. On the top, you see, actually these are actually same progression-free survival, but the overall survival, there were more deaths on Imatinib arm compared to the 400 milligrams twice daily Nilotinib arm. However, that's not the standard dose that we use. But if you look at deaths due to advanced CML, there were more deaths in Imatinib arm than Nilotinib. So that means there's some toxicity with these drugs, indicating that even though you reduce the incident chance of dying from CML, but there are other toxicities that emerged on this drug. So what are the different toxicities? It's mostly cardiovascular events. These are the incidents of cardiovascular events that are basically categorized in terms of the time to development. So as you can see, more patients treated with high-dose Nilotinib arm had cardiovascular events as compared to Imatinib. Whether this is due to the adverse effect of the Nilotinib, or it was thought that Imatinib may have some cardioprotective effect, so it's not known. And this is a recent review paper from my mentor, Dr. Deininger. So they looked up all the cardiovascular rates, toxicities in patients treated with Nilotinib across various studies. As you can see, anywhere up to 2 to 6% of the patients developed some kind of cardiovascular toxicity. So there is benefit, but you have to consider the toxicity that comes with that additional benefit in treating with second-generation inhibitor. So the next study that I want to just go over very quick is the Decision study. It's also an industry-sponsored study that the multi-center, multiple countries compared Dasatinib 100 milligrams once daily versus Imatinib. And the primary endpoint is CCYR, which is a complete cytogenetic response. That means absence of any Philadelphia positive chromosomes at 1 year. This is the patient dispersion at 5 years. Once again, about 60% of the patients in both arms remained on their assigned TKI at the end of 5 years. And in the bottom, it highlights what was the reason for discontinuation. So I'm showing MMR rates rather than the primary endpoint of the study so that we have some comparison. So patients treated with the second generation inhibitor, Dasatinib, has higher rates of major molecular response at 1 year, and this was maintained up to 5 years. So 76% were in MMR at 5 years as opposed to 64% on Imatinib. And if you see with Nilotinib, there was a little bit, it's about the same. In terms of MR 4.5, which is the sort of the deeper molecular response that may allow patients to discontinue their TKIs, is also significantly higher in the Dasatinib arm compared to the Imatinib arm. But if you go back in Nilotinib arms, there were more patients that got a deeper molecular response. The overall survival and progression-free survival are not too different, although as you can see here that more patients have transformed to accelerate phase or blast phase when treated with Imatinib compared to Dasatinib. Now, Dasatinib also comes with certain adverse events. Those are cardiovascular, can be peripheral arterial disease. The incidence of these are much higher in Dasatinib arm. And I think another important toxicity that needs to keep in mind is development of pulmonary hypertension in patients treated with Dasatinib. It can happen very early, or it can happen very late in the treatment course. So what about non-industry sponsored studies using second-generation inhibitors upfront? This is an intergroup study that was put together by Jerry Radish from Fred Hutch. So this is comparing Dasatinib to Imatinib, and the 12-month MMR rates were higher with Dasatinib as we saw in the Disposition study, but there was no significant difference in terms of progression-free survival and overall survival. What about dose intensification of Imatinib? Can you give higher dose of Imatinib, like 800 milligrams once a day? This is again an intergroup study that was put together by Dr. Deininger. And as you can see, there are higher rates of MMR and MR 4.5 in patients with high dose Imatinib as opposed to the low dose, but there were more discontinuations in high dose because of musculoskeletal related side effects. And there was some improvement in progression-free survival with high-dose Imatinib. The 4-year PFS was 92% as opposed to 80% with 400 milligrams, but the overall survival was not so different. I'm going to skip this. So what do we take from this? So you get deeper responses with second-generation inhibitors compared to Imatinib. The MR 4.5 rates, much deeper molecular response, are higher in Nilotinib, or slightly higher as compared to Dasatinib, and there are reduced probability of progression to accelerate phase or blast phase. There's some improvement in overall survival with Nilotinib higher dose arm, but that's not the standard dose that we use. The bottom line is you use your clinical judgment. One thing, though, that's clear is that Imatinib may not be an optimal choice in high so-called risk patients. So there you could consider doing a second-generation inhibitor. But in low so-called risk patients, Imatinib is an excellent choice considering the long-term safety of this drug. So this is another study that was presented at ASCO recently. Before study, basically trying to get first-line approval for Bosutinib. So there was one phase 3 randomized study that compared Bosutinib versus Imatinib, but it was a negative study. And it was felt to be because the dose of Bosutinib used in the study was 500 milligrams, so that gave more GI side effects in the beginning, and a lot of patients discontinued. So ultimately, it didn't lead to first-line approval. So they put together a second phase 3 study. The Bosutinib dose was reduced to 400 milligrams once a day versus Imatinib, all chronic phase CML patients and newly diagnosed. And the primary endpoint is MMR rate at 12 months, and there were other secondary endpoints too. And this was the data that was presented. I want to focus on the far right. At 12 months, the rates of MMR were higher in patients treated with Dasatinib, as well as MR4 and MR4.5 was also higher. So this might lead to another option for frontline management of chronic phase CML patients. And there were also some decreased risk of progression, about 1.6% on Dasatinib arm progressed, as opposed to 2.5% on the Imatinib arm. So now I'm going to talk about a little bit about monitoring therapy. This is the sort of the classic inverted pyramid. So you have about 10 to the power 12 leukemic cells at the time of diagnosis, and as patients continue the tyrosine kinase inhibitor, you get to various levels of depth of response on this TKI. On the left side is the BCABL PCR on the international scale. So a 3-log reduction of BCABL PCR on the international scale is considered MMR. And what is deep molecular response is anything below MR4, which is a 4-log reduction in the BCABL transcript levels is considered a deep molecular response. That becomes more relevant as we understand the biology of the disease more and who can stop the TKIs. So the problem with the PCR is the sensitivity. I think they're doing a little bit better in the European Union in terms of having a uniform standardized test, but in the United States, it's a challenge. But people have come up with certain definitions, what is considered a good quality result. But most the laboratories should be able to essentially amplify enough copies of the control gene to say before they determine the level of BCABL. This is mostly relevant to the labs than clinicians. So there are some attempts to improve the sensitivity of the testing. A digital PCR is one thing. This was essentially pioneered by Jerry Radich at Fred Hutch. It might come into clinical practice in the next few years. The principle is that they amplify each molecule of BCABL in a separate well, and then come up with the total number of copies of the oncogene. And there's about 2 to 3 log improvement in terms of detection sensitivity, but as you know, this is not there in the clinical practice yet. But many countries don't have access to PCR testing. For example, in sub-Saharan Africa, there were only 2 countries that were able to do the monitoring. So if this is not available, monitoring bone marrow karyotype in the bone marrow aspirate is also an equally good alternative. So in terms of recommended monitoring, these are European Leukemia Network guidelines. So you're supposed to get a bone marrow karyotype at the time of diagnosis, and they recommend to document a complete cytogenetic response by doing follow bone marrow biopsies every 3 months. That might be a little bit more intense, but in my practice, I would recommend to patients usually get a follow-up marrow to document a complete cytogenetic response at 6 months, and if they're negative, undo again in 12 months. But majority of the patients get CCYR by 12 months. And then once you get to the CCYR, you're supposed to monitor the BCABL PCR every 3 months until they get MMR. And once they get MMR, you could relax a little bit and do every 3 to 6 months. It is pretty critical in monitoring. We know that CML patients do really well, but but patients who are not monitored, who lost to follow-up and not compliant with the medications are going to do really bad. And then BCABL mutation analysis should not be performed at the time of diagnosis because low-level mutations at diagnosis do not predict the response. So therefore, it should not be routinely done. But anytime patients fails a tyrosine kinase inhibitor, you should get a BCABL mutation analysis. In the real-life practice, the monitoring is not done as stringent as is recommended. That's probably why it explains why we cannot replicate the success that you've had in all these randomized studies. For example, in one study that was that was published in 2014 called Simplicity Study, they looked up how many patients had response for both bone marrow karyotype or molecular response, and only 28% had at least one test, and both two tests were done about 30%, and essentially about 16% never had any level of monitoring. So the key is to monitor these patients on TKI and to maintain compliance and also pick up resistance. So there's some therapeutic milestones I think you should watch. At 3 months, you should get a complete hematologic response. That means normalization of blood counts and complete and resolution of splenomegaly. If you don't get that, that's considered treatment failure, so you should look into compliance and also for emergence of drug-resistant mutations. And then there are other time points that you need to keep in mind. So I'll move forward. So one of the things that has emerged is if the BCABL PCR level at 3 months is less than 10%, these patients do extremely well. It's an excellent surrogate for predicting long-term outcomes. But the patients who has a BCABL PCR of more than 10% at 3 months have significantly reduced overall survival. And this was on Imatinib, and it was confirmed in multiple other studies, including upfront treatment with second-generation inhibitors. I'll move forward. So the other thing that Australian group also looked at is the velocity of decline in BCABL, and they basically came to the conclusion that if the BCABL halving time is less than 76 days, even among particularly among patients with more than 10%, there's difference in outcomes. I'm going to skip some of these slides. So one of the things it's can be tempting to do is if you fail to get an early molecular response at 3 months, which is what basically BCABL PCR on international scale less than 10%. If you fail to get that, it's kind of tempting to switch to a stronger tyrosine kinase inhibitor, but we don't have any data to support that. So the other thing that's important that has emerged, this is from the German CML4 study. Essentially what they concluded is that it's the comorbidities that determine the outcomes of CML patients. So the chance of dying with CML is very less likely, and it's mostly the comorbidities that dictate their long-term survival. Okay, in terms of identifying resistance and salvage TKI selection, so recognizing TKI failures is important. And I would recommend to look at the algorithms. If patients fail to reach the milestones at different time points, that's definitely a TKI failure. Or if patients who responded really well, but then subsequently lose response, for example, loss of complete hematologic response, that means that the white count starts to going up, or if you see splenomegaly, or if there's loss of complete cytogenetic response. In some situations, if patients get to an MMR and they lose MMR, then that's considered TKI failure. Another thing is to pick up preclinical before it becomes clinically apparent, which is essentially that's why you monitor PCR every 3 months. So if there is more than 1 log increase in the BCABL transcript levels, you should confirm that with the second test after 4 to 6 weeks, and if it's still high, then evaluate with for kinase domain mutations. And typically, when you meet any of those criteria, the first thing is look for compliance, drug interactions, and also, and then if you rule those out, you should do a bone marrow biopsy to look for clonal evolution, and also look for the BCABL mutation test. So the factors that influence selection of salvage TKI is based on the disease phase at the time of loss of response, kinase domain mutations, the previous treatment history, and also other comorbidities. which I'm going to review briefly. So there's several different point mutations in the kinase domain, the pocket where Imatinib essentially binds to and inhibit the phosphorylation of the oncogene. And the presence of these kinase domain mutation essentially cause steric hindrance and not allow the drug to bind to the pocket. So there are a variety of mutations, but fortunately the second generation inhibitors like Nilotinib, Bosutinib, and Dasatinib will cover most of the other mutations, although they have differential sensitivity to certain mutations. But one mutation that to watch out for is T315I. Here, threonine at the 315 position, which is a gatekeeper residue of the kinase domain, is replaced by much bulky isoleucine. And the presence of this mutation confers resistance to all second generation inhibitors, and the only option in that situation is the third generation drug, Ponatinib. So this is a heat map, not try to, essentially showing that if you have this point mutation, on the top you have Imatinib, Bosutinib, Dasatinib, and Nilotinib, and Ponatinib. The pointer doesn't work, but T315I is somewhere in the middle. If you have T315I, it's red is resistance. So basically resistant to all TKIs except Ponatinib. This is all what we have in vitro sensitivity data. It's an imperfect correlate of in vivo efficacy. So if you have a development of a mutation, if you're not sure what TKI to pick, you could contact Dr. Deininger or myself if you need some help in selecting Salvage TKI. So these is the results of the PACE study that was done in, it's a phase 2 study, basically had CML and Philadelphia positive ALL patients that are resistant or intolerant to either Dasatinib or Nilotinib, were treated with Ponatinib, and the primary outcome was a major cytogenetic response in chronic phase CML patients, but in blast phase is a major hematologic response. And these were the data. This was the data that was presented at ASCO. So one thing to highlight is if you have T315I mutation, there's about 70% chance of getting a complete cytogenetic response. So Ponatinib works really well in patients with T315I. And responses were also seen in patients without a mutation, and we actually don't know how these patients fail TKI even though there's no mutation. They respond to, but much to a less degree. So Ponatinib is your to-go drug if there is a T315I mutation or if they fail more than 2 TKIs. We did some laborious sequencing and to look for patients who fail Ponatinib, and essentially what we found was if you have compound mutations, that means more than one mutation in the same BCABL molecule, then even Ponatinib doesn't work on those. But those are rare and less likely to happen. Okay, and this is one case that I treated. This patient has a compound mutation, E255V, and a T315I at a low level at the time of diagnosis. And this patient relapsed after 3 months on Ponatinib. The white count increased to 40,000, and we showed that 100% of the clones had this compound mutation, and we did some structural analysis to show that if you have both mutation, even Ponatinib cannot bind to the TKI. Now I'm going to skip the next few slides. I think this is important. If you treat with first-line Imatinib, your options are the second generation inhibitor and Ponatinib only in the presence of T315I. There's about 50% chance of responding with second generation inhibitors. But if you fail one of the second generation tyrosine kinase inhibitors in the second line setting, probably Ponatinib is a better option. You have about 50% chance of responding as opposed to only about 20% if you switch to another second generation TKI. And again, you should take into account comorbidities. So then we come to treatment-free remission. We have a couple of minutes to just quickly highlight this concept. So in the United States, we're quite behind in terms of identifying patients that can stop tyrosine kinase inhibitor. But in France, they put together this trial a long time ago, but this is a long-term data. So they took 100 patients that were treated with imatinib, all have to be in chronic phase patients. And these patients achieved a complete molecular response. That means the BCABL was negative by an assay that is highly sensitive. And they had to be negative for at least minimum period of 2 years. And then they stopped the tyrosine kinase inhibitor, imatinib, and monitored their BCABL PCR every month. So you have to monitor really stringent if you decide to stop. So what is really fascinating is about 40% of the patients were able to discontinue tyrosine kinase inhibitor at 5 years. And in the bottom, there's a small table here. Most of the recurrences happen in the first 3 months. Actually, in the first 7 months, almost 95%. And there were 3 late relapses between month 18 and 22. The message is that if you're going to relapse, I shouldn't call relapse. The better term is molecular recurrence, because you're looking for detection of BCABL again. So the molecular recurrence occurs most commonly in the first 7 months after stopping TKI. It's coming into real life practice soon. If somebody wants to discontinue, you could, but you have to remember that you need to monitor the PCR levels every month. And similar data was seen in an Australian study and also a Japanese study. So the other interesting thing the Australians did was they took patients who were able to discontinue TKIs and used a highly sensitive assay to detect BCABL by DNA-based testing. And these patients were still positive for BCABL DNA, even though they had no molecular recurrence. So that means that you suppress the clone too low that it cannot essentially repopulate in the bone marrow again. The next question the French people asked is, well, we're able to stop this TKI in some patients, but when do you restart the tyrosine kinase inhibitor? In the initial STIM study, they restarted when they became positive, essentially tested again after a month later, and if it's still positive, started the TKI. But then in the follow-up study, what they did was they took about 100 patients, and they only restarted the imatinib if they lost MMR. So they waited until they lost MMR, and in the top one, as you can see that the incidence of recurrence is much lower if your threshold of restarting is higher. Another important thing that they showed is that once you relapse and you put them back on TKI, almost all of the patients recaptured the previous level of response, but it took some time for some of those patients to get there. So this is the summary of all TFR studies that I put together. Essentially showed anywhere from 40 to 60% chance of able to stopping the TKI. There's one slide that I want to show you is something called a STOP2G TKI. This was done in Europe. This was patients treated with second-line tyrosine kinase inhibitors with second-generation drugs. So they also have about 60% chance of stopping Dasatinib. Once again, all these patients had at least MR 4.5 for a minimum period of 2 years. And the interesting thing that they saw here is if you failed imatinib in the first-line setting because of either or you were resistant to imatinib, you have less chance of able to discontinue even in the second-line setting. Because some of these patients switched to second-generation inhibitor because they were intolerant to imatinib. So, and similar data was also seen in another Japanese study. So the other interesting thing is sometimes when you stop TKI, these patients develop side effects that are considered to be withdrawals sort of syndrome. There was some hypothesis that these drugs also inhibit mast cells. So if once you take off TKI, the mast cells go up and you can develop side effects. And there's some predictive clinical biomarkers, but right now I think the longer you are on TKI before stopping has the best chance of predicting success of stopping TKI. So those are the take-home points. What I would say is monitoring is the key, and early molecular response is associated with superior outcomes. There's some questions in the end you can look up later. So I'd like to thank people who contributed to the slides and also Dr. Deininger, who mentored me over the last few years. Thank you.